So I think that the treatment and the management of lymphoma generally during the COVID pandemic has been different things for different countries. However, every country has developed their own risk-based and resource-based adaptations to the management of patients. And I think that's very important that we separate the two things, because there's what you do based on the risk for that individual patient with high-grade lymphoma needing treatment, for their disease, cannot delay their rituximab CHOP chemotherapy. However, if they're in circumstances where you're considering something even more intensive without any good phase 3 data in support of that, you may feel quite happy in the COVID environment of just giving them the CHOP-based approach. Conversely, the patient with indolent lymphoma who really doesn't yet meet criteria or doesn't firmly have clear evidence of rapidly progressive or symptomatic disease, we can delay, and everyone certainly globally has been delaying the commencement of treatment for these patients with advanced stage follicular lymphoma. And also with these patients in the height of the COVID pandemic, we were making risk assessments about the appropriateness of utilising rituximab or obinutuzumab maintenance therapy for these patients. And even the initial chemotherapy, a number of us were initially reluctant to use bendamustine rather than CHOP because of its prolonged immune suppressive effect. So, there have certainly been risk-based approaches. But also, I certainly know in Australia, where we were very fortunate not to have huge resource limitations, certainly there really had to be resource-based decisions about the treatment of patients, because there is no doubt once you lose, say, 30% of your nursing staff in the ambulatory care setting, because they're off because of, they're in quarantine or they've got COVID themselves, you certainly have a huge impact on your ability to treat patients with lymphoma. So again, it was the patients requiring maintenance therapy who would be deferred in a resource-based allocation setting. And generally, I think clinicians around the world have been very careful to try and protect the quality of their care where it impacts on survival, to ensure that the resources are there to treat these patients. And so it's more the things like the bisphosphonate therapies for patients with myeloma that got delayed, the iron infusions that got delayed, the less urgent therapies that were delayed because of resource limitations. But I think it would be very wrong for me, other than making these broad brush statements, to make any comments about the impact of COVID globally, where we were so little affected here in Australia. And my heart goes out to my colleagues in the UK, in the US, and in South America and elsewhere who have really, really struggled with making these risk and resource-based decisions, and the sheer workload and the physical and the emotional challenges of COVID.